Okay. Okay. So we'll just recapitulate what we have studied in last two classes. So more of we have studied the common clinical presentation of renal diseases, and then we talk about what is hematuria, what is proteinuria, and what are the common manifestation, how what are the different types of edema, very important symptoms of it, symptoms in many patients, not only kidney patients, but edema is one of the very common symptoms in respiratory system when their lungs are damaged, and they can cause some heart problem which is called cor pulmonale. So even respiratory patient can have edema, even cardio patient can have edema, liver patient can have edema. So we have to know edema in and out. So I think I hope you have read what is edema from MacLeod also. So in last class, we were discussing about what are the common presentation of uh, renal diseases, right? So after we know the common clinical manifestation like hypertension, edema, and all those symptoms of hematuria, passes of red color urine. So now this slide showing you common uh, disease, how the patient of kidney disease will present to you, and I've explained what is asymptomatic patient. Those patient which are diagnosed only in the during screening program. Sometimes we do community screening program. They don't have any symptoms, but patient is suffering from some kidney disease. Any earlier phase, maybe they have very mild symptoms, which they correlate with some other factor, like many of our patients who are living in the very cold areas. They say, oh, this is due to cold, the swelling is due to cold. So they have so many other correlation, but actually they are suffering from disease. So the asymptomatic patient, other group of patient comes with a macroscopic hematuria. They will tell you, I am passing red color urine, and I have told you how to differentiate this by looking at the color of the urine. By inquiring the color of the urine, we might differentiate whether this is a hematuria, or the blood in the urine is from the kidney or the collecting system, right? But I told you this nephrotic syndrome and nephritic syndrome is one of the very important topic in our chapter. So these two syndromes has to be memorized, and will frequently asked question in MBBS final, in ICM as well. So I will go in detail about nephrotic and nephritic. But before that, if you see the last two boxes, one is written rapid RPGN. The full form is rapidly progressive glomerulonephritis, and other is a chronic glomerulonephritis. So I'll just highlight. Maybe you don't need so much of detail in the at your level right now. But rapidly progressive glomerulonephritis are the kidney diseases where within months, today the patient is normal. They will just come with some mild hematuria or mild proteinuria, and slowly within weeks, not in days, but within weeks, the creatinine will grow, increase and increase, and ultimately within few months, the patient will land up in chronic kidney disease, and ultimately they have to go dialysis or they have to go transplant. So these are very fatal conditions, like you must have heard some anti-GBM syndromes, good passer syndromes. They cause, if you don't diagnose on time, they can cause both the kidneys into the chronic kidney disease, and then you have to offer them only dialysis or maybe transplantation. So RPGN is a group of disorders which will destroy the kidneys within days to month, you know, and these people will also have some hematuria, and they have some proteinuria, but not so much of proteinuria like in nephrotic syndrome, but they have less than 3.5 gram per day proteinuria, and hematuria will be there. But we follow up, we do follow up with the creatinine. Like today, the creatinine is 2, and then again after a week, maybe it become 2.5. Then after a week, it become 3.5. So weekly, we see increasing and increasing. And if you don't give high dose immunosuppressive, we have to do a biopsy whether this is due to vasculitis, whether this is due to anti-GBM syndrome. You have to give high dose of steroids and some other immunosuppressive, or sometimes plasmapheresis. Then only we can stop this progression of the disease. Otherwise, they are very fatal. And within months, patient was very okay a few months back, but within 2 or 3 months, if you don't treat on time, not even 2 months, in 1 month, they will just land up in chronic kidney disease. After that, your kidney is not salvageable. And if you see the last box, so this is the chronic glomerulonephritis. So any acute condition, so you must have read acute inflammation lead to the chronic inflammation in pathology, right? In Robin's pathology, there's so many inflammation are there, chronic inflammation. So when the kidney are diseased for a long time, when the kidneys, patient doesn't know, maybe he is in asymptomatic phase, or patient is not able to seek the medical advice. Sometimes the patient is having hypertension, and they are just taking hypertension medication from the local medical health, and they have not done their USC to look for kidneys. They have not their urine routine. They have not done creatinine, and ultimately they will come to us with a creatinine of 8, 9, 10. And we ask them, yes, I have hypertension. I have not checked my creatinine. I have just taking the blood pressure medicine. So these are patient was suffering from some acute GN, and ultimately the patient will land up to the chronic glomerulonephritis. So any disease, when you have a chronicity, then that is manifested by the fibrosis. So the hallmark of chronic inflammation is fibrosis that occurs in other parts of the body also. So same thing happen in the kidney. If the acute inflammation is going on inside the kidney, then if you don't stop that inflammation on time with the medication or any other procedure, then ultimately with the time this become chronicity, and kidney start shrinking. So our normal kidney size is suppose 9 to 12 centimeter length, and what we do a USC and we check for kidney size. If it's less than 8 centimeter bilateral, then we consider this is chronic glomerulonephritis. And once we diagnose chronic glomerulonephritis, there is not much to offer to the patient, because no medication can revert this chronic glomerulonephritis to normal. So in those cases, we just have to delay the progression by halting the any other disease. What is the primary disease, like maybe hypertension or maybe diabetes or any other glomerulonephritis? We can use some other drugs just to slow the progression of disease, but we can't cure the disease once we have a chronic glomerulonephritis. So these chronic glomerulonephritis are manifested by hypertension, small size kidneys, and they are bilateral small size kidneys, and these small size kidneys are smooth kidneys. And there is a rare condition, like in science, in medicine, we always have exceptions. So there are few conditions, even in chronic glomerulonephritis, the size of the kidneys are normal. So those cases, if you want to know, those cases are like diabetes. The long-standing diabetes can lead to chronic glomerulonephritis. So in diabetic patient, the kidney size can be normal, but still patient having chronic GN. While I have written over there in the box, this should be less than 8 centimeter. Yes, that happens in maximum cases, but there are few exceptions, like polycystic kidney disease. The bilateral cysts are there. You have palpable lump in the abdomen when you palpate it, but patient is having chronic kidney disease. But the cyst size are not small, and eventually the kidney size also will be like big, 18 centimeter bilateral, but still patient having chronic glomerulonephritis. So you should know some exceptions like lymphomas, HIV nephropathy, amyloidosis, diabetes, polycystic kidney disease. There are the few exceptions. Even the kidneys are normal in size, we there is a chronic glomerulonephritis. So somebody can ask you, does it all the chronic glomerulonephritis have small kidneys? So if you know these exceptions like diabetes, you have to remember diabetes because it's so prevalent in worldwide. So diabetes, kidney disease, though creatinine is 5, 7, if it's only due to diabetes, then kidney size can be normal, but is chronic kidney disease. Okay. So we will talk about more detail in about nephrotic syndrome and nephritic syndrome. It is so common. So why I have kept this slide, the previous slide in the boxes is it is very difficult for some time for us to differentiate whether the patient is suffering from RPGN, chronic glomerulonephritis. So what is the disease? It is very difficult when you get the patient of some, urine reports are abnormal. There is a blood in the urine. There is a protein in the urine, and patient has so many other history. So what I personally want to do is whenever I see the patient of kidney disease, then of glomerulonephritis, then I want to put that patient in one of the boxes. In one of the boxes, whether is a asymptomatic patient, whether patient is a macroscopic hematuria but no other symptoms, whether there is so much of swelling, 24-hour protein becomes more than 3.5 gram per day, your high lipids, low albumin. Oh, this is the nephrotic syndrome. Then I start investigation in the line of nephrotic syndrome. Likewise, if the patient has very short history, gives some bit of swelling, some bit of proteinuria in the protein in the urine, then I put in the nephritic syndrome. So doing so, it is easier for us to investigate. Otherwise, if you see the investigation in our field in our kidney disease, there is a lots of investigation, to do, and there are very expensive investigation also, and some are invasive investigation which patient won't be ready to go very spontaneously. So because if you want to send, if you are thinking the patient is of rapidly progressive glomerulonephritis, and you want to send all the parameter of ANA, dsDNA, and there are so many other expensive tests, and but the patient is having nephrotic syndrome, it is no use, right? Because the investigation will be different. So you have to fit in that patient uh, uh, in one of the boxes, and it is easier for us to go further. Okay. So please, I again repeat, please and please try to know what is all my 81 81 people are here, maybe 80 are here. One of is me myself. So please remember this again. We have discussed this again. This will be frequently asked. Out of 80, maybe 40 will be asked one time in the MBBS, and other maybe in MD also. So nephrotic syndrome, please remember only one. If you want to remember only one finding, is the massive proteinuria. What is nephrotic syndrome? Massive proteinuria. And they will ask you, what is the value of that massive? What is the massive? Massive means if you quantify the 24-hour protein, we ask the patient to collect the urine from 7 a.m. to 7 a.m. next day. That becomes 24 hour. So they will collect in the gallon, and they will come to the lab, and they will leave that urine 24 hour, all urine, maybe 2 liter, 3 liter, 4 liter, how much urine is passing. All urine has to be collected in the gallon, and that urine will be quantified for the protein. And if you have more than 3.5 gram per day, it's not 3 also, it's 3.5 gram per day protein, or 3500 milligram per day, then we say this is a massive proteinuria. So once you are losing so much of protein, say what will happen in the blood? Then again you have a less protein in the blood. So we say this is the less albumin, less than 3.5 gram per deciliter. If you have a less albumin, then you will certainly develop edema. Right? So this is the chain reaction. If you remember one symptoms of that nephrotic syndrome, then you can make up with your own, with your using your own brain, right? So if you are losing so much of money, then you become poor. That is the understood thing. So if you are losing so much of albumin from urine, then your albumin become less in the body. Eventually, you develop edema. If you have less albumin, our liver wants to synthesize more albumin. So there will be while doing so, there will be lipid will be also synthesized, and there will be lipid will be LDL will be very high, TG will be very high, and because of so much of high lipids, you can see sometimes lipid in the urine, that is called lipiduria. So at least if you not don't remember number 5, but at least 4 cardinal symptoms of nephrotic syndrome has to be remembered. Okay. So in the other counterpart is a nephritic syndrome. which is acute in onset, and this is again characterized by mild edema, because the proteinuria is not so high. That is called non-nephrotic or subnephrotic proteinuria. We say subnephrotic means less than 3.5 gram per day, because nephrotic is more than 3.5 gram per day. Suppose somebody is losing only 2000 mg per day or 2 gram per day, then we say subnephrotic proteinuria. And there is a edema, because patient is not passing so much of urine. I told that they have some oliguria. So if you have passing less amount of urine, then because of retention of sodium and water, you will have edema. Because of sodium and water retention, you will have consequently hypertension also. And one thing you have to remember is nephritic syndrome is there has to be blood in the urine. Okay, without blood in urine, we don't diagnose a patient with nephritic syndrome. So whenever somebody is diagnosed, oh sir, this is the nephritic syndrome, I always check whether there is RBC or not. That also has to be more than 3. Okay, and the pathognomic, this will come in your MCQ. What is the pathognomic of nephritic syndrome in urine, or glomerulonephritis, acute glomerulonephritis, which is the same meaning? Sometimes they come with like AGN, sometimes they come with the nephritic syndrome. So both are same thing. So you have to say what is the pathognomic finding in the urine is a red cell cast. When these red cells pass through the tubules, then what happened is, there is a time horseful protein in the thick ascending limb. That is normal protein. Like I told you, what is the normal consistency of the urine. So this normal time horseful protein, or sometimes the other name is uromodulin. Maybe you will be taught in the physiology. So this protein will embed the RBC. Okay, and they become, because the normal morphology of the tubules is cylindrical, right? So tubules are tube, it's a tube, so it's a cylindrical. So they take the shape of tubules and become cylindrical shape. So if you define what is cast, it is a cylindrical structure. If they embed RBC, it's called RBC cast. If they embed WBC, then it's a WBC cast. So what I want to make you understand is, whenever you are dealing with a glomerulonephritis, acute glomerulonephritis or nephritic syndrome, then red cell cast are the pathognomic of nephritic syndrome. There has to be a blood in urine. Having said that, nephrotic syndrome, usually there is no blood in urine. Usually, sometimes nowadays the things are changing, science is changing. There are so much of research is going on. So in some causes of nephrotic syndrome, we might get some amount of blood hematuria in some nephrotic syndrome. But at your level, if you don't want to remember that, then forget it. So nephrotic syndrome, 99% there is no blood, okay, in the urine. But nephritic syndrome, 100% there has to be blood. Then only we diagnose them as the nephritic syndrome. But nephrotic syndrome nowadays, if you see the books nowadays, there are so many causes of nephrotic syndrome, like membranous nephropathy, focal segmental glomerulosclerosis. So those causes, sometimes you get blood in those kind of nephrotic syndrome, but minimal change usually don't have blood in the nephrotic syndrome. So for your label, you can just stick to nephrotic syndrome. There is no blood in urine. Nephritic syndrome, there has to be blood in urine. Okay, so this is the picture. This is the table which show the differentiating point. How do you differentiate nephrotic versus nephritic? So if you see somebody unmute the mic, Rahul Singh. Is it Rahul Singh is having mic is on? Thank you. So if you see this table, nephrotic versus nephritic, so you have to know this also. So see the onset. So the patient of nephrotic syndrome will present to you with a history of maybe 2 months, 3 months. Insidious, slowly onset. But nephritic, whereas in nephritic syndrome, it's a very abrupt one. Within weeks, they will come to you for the sake of medical advice, because they are very abrupt. So they will tell you, maybe 2 weeks. 2 weeks, I had one sore throat, and after that sore throat, then after 7 days, 10 days, then I started having passage of color urine, and then now I have edema, and I have some shortness of breath. I'm headache because of hypertension. So the history will be within 2 weeks, 1 week, 2 weeks, 3 weeks. But if you see the nephrotic syndrome, they say the onset is insidious, then they will tell you maybe, oh, I have some mild degree of swelling in my limb, which was started from 3 months back. Then I, took some medicine from local health. Then maybe after 1 month, 2 month, then only 3 months after many long time only they will come to you with a generalized swelling. So the insidious is insidious onset. Number two is edema. Because of the proteinuria, heavy proteinuria, there is more edema, pronounced edema in nephrotic, but nephritic have less edema because it is not the proteinuria, it is a retention of the oliguria or retention of the uh, fluid and sodium, which causes the edema. In the nephritic syndrome, the pathology a bit different. Blood pressure will be normally in nephrotic syndrome is normal, but in nephritic syndrome usually it is raised. So, and JVP. Somebody know JVP? Kusal Singh Basnet, are you there? Kusal Singh Basnet, are you there?
Yes, sir.
Very good. Do you know what is JVP? Do they taught you
Jugular
what
venous
is?
pressure.
Very good. Is written over there. Do you know which jugular vein we use, external or internal, to see the pressure?
Internal jugular vein.
Very good, very good. Internal jugular vein, right? This is also very important question. Internal jugular, why internal jugular vein is choose for measurement of the right atrial pressure? Because it is straight. There is no valve, right? There are so many points from MacLeod. Please read this. I am sure that you will be asked in your exam. So jugular venous pressure. Thank you. So you can unmute your mic. So jugular venous pressure will be normally normal in nephrotic syndrome, but it is raised in nephritic syndrome because what happens is if you have more water inside your body, you know, more water inside your body, that also intravascular volume, because your edema is not much in the nephritic syndrome. That means the fluid is not in the interstitial space, the fluid is still in the intravascular compartment. So what happens if you have a more fluid inside your intravascular compartment in the blood vessels, then you have raised JVP. And this JVP is not only seen in nephritic syndrome, it is very good clinical marker to see the cardiac failure and many other conditions. So it is very important part of clinical examination and frequently asked in MBBS. How do you see jugular venous pressure? So somebody will teach you, and don't worry about that. But if you see the nephrotic syndrome, JBP is usually normal or low, and somebody will think, oh, there is so much of fluid in the nephrotic syndrome, how this is normal and low? So my answer will be, though there is a fluid, so much of fluid in nephrotic syndrome, though there are bloated like a balloon, filled with a fluid, patient will gain 10 kg, 10 liter, 20 liter of water because of nephrotic syndrome. And but this fluid is situated in the interstitial space, not in the intravascular compartment, because the fluid has moved out from the intravascular compartment, and there are more there is situated in the interstitial space. So if you have a less intravascular volume, then it is maybe low JVP or normal JVP. So in nephritic syndrome it is raised, in nephrotic syndrome it can be normal, right? So proteinuria, you can see by definition, nephrotic should be 3.5 gram per day. Please remember 3.5 gram per day nephrotic syndrome, and it is less than 3.5 gram per day in nephritic syndrome. Hematuria, so I told you, may or may not occur. At this point, you just want to forget it. Hematuria is not present in nephrotic. That also is fine. But nowadays, some books are writing hematuria can be there in nephrotic. That if you are studying more and more, then you may know what are the causes of those hematuria. But see the nephritic column, hematuria is 3 plus. So that means hematuria has to be there in nephritic syndrome. Likewise, you see the red cell cast is present in nephritic syndrome. Like I told you, what is cast? It is a pathognomic finding of nephritic syndrome in urine. Somebody asks you what is pathognomic finding of the urine in the nephritic syndrome, or sometimes they can ask you what is the finding in AGN, then this is the racial caste. So serum albumin, the last one, if you are losing so much of albumin in the urine, proteinuria, heavy proteinuria is definitely going to be low, but in nephritic syndrome, serum albumin will be normal. So this is how we differentiate nephrotic versus nephritic. So I'll just briefly, describe about. You don't have to remember so many things, but just want to let you know what are the things. What is acute renal failure? Somebody this acute renal failure, or nowadays we don't use this term acute renal failure. Nowadays the acute renal failure, the term is substituted with the acute kidney injury. Nowadays, we don't use acute renal failure because it's not a failure. Acute kidney injury, if you get on time, you can treat on time, then this injury can be reverted back to normal. So nowadays, the terminology is changing. So we call it as a AKI, acute kidney injury. So nowadays, in newer books, you don't find ARF. ARF, what is ARF? Acute renal failure. Previously, when we were at your level, we say ARF and CRF, acute renal failure, chronic renal failure. Nowadays, same terms are being used as AKI and CKD, acute kidney injury and chronic kidney disease. Okay, so acute kidney injury or the acute renal failure, in previously known as, is a rapidly a sudden decrease in renal function occurring in period of hours to days. So we have to. There is a tricky thing. One thing, RPGN. When I was describing, I told you it is a decrease in renal function within weeks to month. But this renal failure, acute renal failure, occurs within hours to days. Okay. So I'll just give you an example. Suppose there is a normal farmer who has gone to his field to work and he is bitten with wasp. Do you know wasp bite? Wasp bite, if they bite you with a swarm of the bees, hornet bees or wasp, they can cause you severe muscle injury known as rhabdomyolysis, and this can cause you acute renal failure or precisely acute kidney injury. So within hours, patient will come to us with a history of wasp bite, and and then and the patient is not able to pass urine, and there is all the features of renal failure will be there, and we have to do dialysis for a few days, few weeks. Then again, this kidney injury will be resolved, and patient will be again fine. So this acute, if you can uh, find out these patients and treat on time, then this is reversible process, and this is very important part of our being a physician, being a nephrologist. We have to diagnose acute kidney injury because you can give life to the patient because they are reversible. They don't have to depend upon dialysis for whole life. But once the patient becomes chronic kidney disease, then it's not reversible. So they are reversible, but this kidney injury occurs within hours to days. So like, do you know? Anyone knows that some drugs can cause kidney injury, or there are nephrotoxic drugs? Anyone knows nephrotoxic drugs? You must have read.
Lithium,
Lithium, yeah, very very commonly. Yes, the lithium also can cause diabetes.
demaglocylin,
Sorry,
demaglocylin,
demiclocycline. Okay, we don't use so much of demiclocycline. Any other antibiotics?
Aminoglycoside.
paracetamol.
Very good. Aminoglycoside. Please remember aminoglycoside. Somebody answered aminoglycoside. Very notorious for kidney injury. Aminoglycoside. This tobramycin, gentamicin, amikacin. We don't want to use. Being a nephrologist, I don't want to use amikacin, though it's a wonder drug for so many gram-negative and gram staphylococcus. But we don't want to use unless we have other drugs for those bacteria. We want to use other drugs. Okay, so we always tell our other physician also, please use other drugs if you have don't use vancomycin, amikacin at one shot if you have other drugs insensitive. So very good. Aminoglycoside is a nephrotoxic drug. There are so many other drugs like NSAIDs, diclofenac, and brufen, ibuprofen, pyroxicam. They all are notorious for kidney injury. So these are the, so if you want, so it's not that all the patient, we also use sometimes brufen for pain relief. Maybe they don't cause in normal patient, but they can cause renal kidney injury in diabetic patients because they are vulnerable for kidney injury. They are taking 10 medications, they are taking AC inhibitors, they are taking diuretics. Those patients who are vulnerable for kidney injury like diabetes, old age, some cardiac disease, some hypertension. Already patient creatinine is 1.6, 1.7, which is not normal. And if you want to use the painkiller in those patients, I will not prescribe NSAID. I will rather give some opiates. I will rather give some pethidine or maybe some lesser opiates like tablets. Also, we get opidol, tramadol, or maybe codeine, or maybe just simple paracetamol, because these drugs can cause allergic hypersensitivity and they can cause kidney injury. And when you are giving with so many drugs with furosemide, ACE inhibitors, and you add with the brufen, they all can be nephrotoxic, and we don't want to use those drugs. So we should know what are the causes of renal injury, acute renal failure, or acute kidney injury, and this happens within hours to days. Okay, so these is some criteria. GFR. When do you say kidney injury? So there is some you don't have to know. Maybe if you want to know, this is rifle, RIFLE, risk, injury, failure, loss, and ESKD, end stage kidney disease. So if you don't treat on time, then patient may land up to end stage kidney disease, and where the patient can't be revert back. So this acute kidney injury, you have to know the cause. You have to know the cause, and you have to treat on time. Then only you can save the kidney. Otherwise, if you take so much of time, more than 3 weeks, 4 weeks, patient is not. If you see the loss, persistent ARF equals to complete loss of kidney function more than 4 weeks. That means now kidney is going towards the chronic kidney disease. So it's better to stop them in risk when they are just GFR is decreased less than more than 25%, or serum creatinine just 1.5. Injury we call, serum creatinine is double. Failure we call when the serum creatinine triples. So we have to stop on this time. And not only serum creatinine, we have some urinary output criteria also to diagnose patient of AKI or acute kidney injury. Okay, you don't get so much tense. There are so many things you have to study. I'm just trying to give you overview what actually we do with the patient only. They might not ask you at your level, but just to have give an introduction what is AKI, which is very important in our nephrology field. Okay, so this is the staging. Let's not go to the staging also. And this is a very busy slide. I just want to give you the overview how actually we term is as so please don't study it on the boxes. There are so many things on the boxes which will confuse you. I just want to make you understand why how we proceed for the cause, to find out the cause. So one is a pre-renal AKI, one is intrarenal AKI or intrinsic AKI, one is post-renal AKI. So if you know this, you know the types of jaundice: pre-hepatic jaundice, right? Post-hepatic jaundice and hepatic jaundice, right? So jaundice can have you read jaundice? Have you read jaundice?
Yes.
Yes, right. So pre-hepatic jaundice can be due to the hemolysis, right? There is a severe hemolysis, acute hemolysis. You can have jaundice. Hepatic jaundice, like because of some liver injury is there, and there is a cirrhosis. You have hepatic jaundice. Post-hepatic, there is some calculus in the bile duct. You have a jaundice. So same manner, you think of kidney. You think of kidney now. Kidney pre-renal. So before the kidney, there are some arteries, right? There are some arteries which has to be perfused. Our kidney has to be perfused at least with a 65 millimeter of mercury. Pressure should be there to maintain the perfusion. So if any cause the perfusion is less, okay, it's a pre-renal cause of AKI. So that can be due to volume loss. You have a severe diarrhea. Some patients have severe diarrhea. Cholera people, they die with a kidney failure. They don't. They die with electrolyte disbalance. So if the patient has profuse diarrhea and profuse vomiting, and patient will have some kidney injury. That is due to pre-renal cause. So kidney is not having any problem with the kidney, but it is the volume which is not able to perfuse the kidney, and kidney will have less GFR, and you will see the rise in creatinine, and there is a creatinine will rise and rise unless you replace with the volume. So it is a pre-renal cause. So likewise, if you have some cardiac disease, there is some cardiac failure, the heart can't pump the enough blood to the kidney. Again, there is a less perfusion. Again, there is a pre-renal failure. So drugs like ACE inhibitors, ARBs, which constrict and dilate the vasodilation and vasoconstriction effect in the arterioles. So again, that will be pre-renal failure. So ACE inhibitors and ARB also cause nephrotoxicity if you give them when they are volume depleted. Okay. So anyways, so I just want to know, whenever we see acute kidney injury, I want to tell my residents, please see whether it's a pre-renal cause, whether it's a renal cause, whether it's a post-renal cause. So post-renal cause, like patient is having stone, patient is having stone in the pelvis, patient is having stone in the ureter, okay, or urethra. So if both the bilateral stones are there, then again there is a increased pressure, and there is a backward pressure, and the kidney start to damage, and is the post-renal cause, and that will be dealt by the neurosurgeons, right? So we just send to surgeons, please take out this obstruction. Whatever you want to do, please take out this obstruction. They put some catheter, they put some pipes, stents, DJ stents, and whatever they do, but they relieve the obstruction, and maybe the AKI can be improved. So that is the post-renal cause. It's after the kidney. Okay. So now comes to the intrarenal cause, that we deal a lot with the intrarenal cause. So intrarenal cause can be vascular cause, ischemic cause, prolonged depletion of volume. They can cause ischemic toxin. Some, like we have mentioned, aminoglycoside is there in the renal, in the kidney injury, in the intrarenal cause, right? So glomerulonephritis. So these all are called the intrarenal cause. So I want to just highlight, whenever you see the acute kidney injury, somebody asks you what are the causes of acute injury, you don't jump into the so many causes. You just try to classify into like pre-hepatic, post-hepatic, and hepatic. Same manner, you also divide those acute kidney injuries. So pre-renal, they can be pre-renal cause, they can be renal cause, they can be post-renal cause. So if you do like that, then you have more causes to write in the exam. Okay. So this is the same slide, how I want to show you what is pre-renal. So if there is some disease, some defect in the artery, maybe renal artery stenosis, some drugs which can cause, and maybe some volume depletion, is a pre-renal. Some disease inside the glomerulus, inside the kidneys, inside the tubules, then maybe it is a renal. Or if it's after the pelvis, ureter, bladder, prostate, urethra, and that is the post-renal cause. Okay. So you should know some diseases that can cause in urethra. You should know some diseases that can obstruct. So you can just write those, and you will be fine with the exam. After acute, there's always a chronic. That is the cycle. So chronic kidney disease is now, we all are facing so much of kidney disease burden worldwide, not only in Nepal, it's a worldwide. And can somebody tell me what is the number one cause of chronic kidney disease in world? In world?
Hypertension.
Number two. That is number two. Number one?
Diabetes.
Diabetes.
Very good. Diabetes. Okay. So please, from this class, I don't know, you are, I think, studying so many subjects. I don't want to make you more pressure, but at least you should know something at your level, because nowadays when I'm taking ICM exam, they ask you, have you heard CKD? Somebody will just ask you, right? So we won't go so much detail into CKD, but you just try to know what is chronic kidney disease, what is CKD. At least you don't have to be, what he's asking, like that. So just know what is CKD. So CKD, number one cause of CKD worldwide, in Nepal, in India, it is diabetes. Okay. Number two is hypertension. Though they are not disease of the particular kidney, though the diabetes is a disease of endocrine pancreas, hypertension is not disease of kidney itself, but they can damage kidney, and being so much prevalent, one of the first two causes of CKD is diabetes and hypertension. Number three comes with, then only number three will be kidney diseases. Like there are so many kidney diseases will be there, glomerular disease will be there, and then stone disease number four, number five, some genetic disease are there, right? So they will come after one after another. That we'll talk in later part of our lectures. Okay. So I just want to say, when you say CKD, it's when the kidney damage occur more than 3 months. Please remember 3 months from this lecture, from this online lecture. I want to repeat 3 times: 3 months, 3 months, 3 months. So what I want to say is, whenever we write CKD in the diagnosis, then that is a sin to the patient actually, because there is nothing to offer. Then there is not much of thing to offer. It is irreversible, and you are saying that if eventually you are going to replace your kidneys, or eventually you are going to have kidney dialysis. Anyway, that is a different part. But once you write CKD, then that means the patient is having this disease for more than 3 months. Okay, less than 3 months will be acute kidney injury. Less than 1 month, but when the creatinine is suppose 3, creatinine is 2 3 more than normal for 3 months, then that is CKD. Okay, so other, like maybe proteinuria for more than 3 months, hematuria for more than 3 months, and then maybe more than 3 months is always CKD. So if it persists for more than 3 months, any abnormality, then we say this is the CKD. And see, the number 2 criteria is, do you know GFR, glomerular filtration rate? What is normal glomerular filtration rate from physiology? Have they taught you?
120 ml.
Very good. 120, 25. Guyton, Ganong gives a bit of different values. Both are right. So 120 ml is the normal value. If the GFR is less than 60 ml for more than 3 months, again, that is also CKD. So any criteria can be met, that is CKD. Okay, you don't, let's not go into the CKD, so much of CKD. There are so many other things in CKD that will teach you in 5th semester. Just know AKI, acute kidney injury, CKD at this level, you know. So don't worry. But just know 3 months. 3 months would be there to say CKD. Okay, so I've just made some MCQs because in ICM they may ask you ICM. In ICM there is MCQ also. So I put how the MCQ come. You know, which of the following is not associated with the role of kidneys? A, B, C, D.
C. C is a vitamin E.
E, right? Very good. So erythropoietin. Okay, then tell me, where does the erythropoietin release from?
Sir, peritubular capillaries.
Very good.
Endothelial cells present in the
No.
Produced
Yeah.
peripheral
It's some books write peritubular capillary, some book like pericytes, right? So you should know where does it actually comes from, because somebody will tell you, we ask her, do you know? Because they say erythropoietin, and okay, tell me where does it come from? They say kidney. Kidney is so big. Kidney is so big organ, so you can't say kidney, right? So you have to be very specific, because being a medical student, you have to be precise and you have to be very specific. Release of renin, where does it come from? Where does it come from? JG?
so JG cells,
JG cells, right? JG cells. Precisely, there are cells which are located in the smooth muscle of afferent arterioles, which is called granulosal cells. So you can just say JG cells. And vitamin E is definitely not related with anything with the kidneys, right? And but activation of vitamin D, we have discussed in the first class, the physiology, the role of vitamin D, the what you call endocrine function of the vitamin kidneys is a activation of vitamin D 125 dihydroxycholecalciferol. Very good. So the answer is C. All are known side effect of furosemide. Have you read furosemide in pharmacology? Yes. So now tell me, what is not the side effect of the furosemide?
C. Hypercalciuria.
D.
Hypercalciuria. Metabolic acidosis. I think answer is C. Okay. So I will just tell you how does it cause hypotension, because you are losing so much of fluid from the body. Of course, they can cause hypertension, right? If you don't stop on time, and because it stops the sodium potassium 2 chloride channel complex in the loop, then of course that will cause this hypocalcemia, but hypercalciuria, right? Hypercalciuria is you are seeing more calcium in urine. That is also true, because calcium is also excreted by the Lasix or furosemide, because it is needed to have the electrical gradient, potential gradient has to be there to reabsorb the calcium and magnesium divalent cations. Those are divalent cations, they have to be reabsorbed, and this also will be not there. So answer is actually D. Somebody was answering D. Actually, furosemide causes metabolic alkalosis, okay, not metabolic acidosis. So in subsequent lecture, I will tell you how it will cause metabolic alkalosis. But furosemide, and you should know the nephrons. If you know the part of the nephrons, there are different kinds of diuretics. So one acts on the PCT, one acts on the loop, one acts on the DCT, and one acts on the collecting tubules. So those two diuretics like thiazide and loop diuretics, they cause metabolic alkalosis, but those acts on the proximal tubule, they cause metabolic acidosis. So the answer will be D. Okay, hypercalciuria, they cause hypocalcemia. So if you are giving Lasix, then you are losing more calcium in the urine. That is equals to hypercalciuria, and you have less calcium in the blood if you are using so much of Lasix or furosemide. Do you know why it's called Lasix? Why the name of the furosemide is Lasix? Why the name of the furosemide is Lasix? Can anybody can answer? Because if you have read Lippincott or any other pharmacology book, they write in bracket Lasix. That is the generic name for, trade name for, it's a what you call, it's an inventory name for the furosemide, Lasix. Do you know what is Lasix means? Anyone can guess. This is not your exam. You can guess. I can't fail you.
It excretion of 6 substance.
Very good. Okay, it is very near to you, Suman Adhikari. Okay, it is quite near. LAT6. So the action of the furosemide lasts for 6 hours. That's why LAT6. Okay, lasts for 6 hours. So the duration of action of the furosemide is 6 hours. So LAT6. LA is last for 6 hours. LAT6. Okay. Anyways, so that's why the name became LAT6. Anyway, so I think now you won't forget what is Lasix, because Lasix is a brand name of furosemide. Okay, very wonder drugs. And number 3, nephritic syndrome is associated with all of the following except A, abrupt history, B, low GBP, C, oliguria or anuria, D, hematuria. Except
B.
Yet, so we can go through that table. Low JVP is not the answer, is a high JVP because of retention of the fluid and electrolytes, sodium and water inside the intravascular compartment. Hematuria has to be there. Oliguria is usually a presentation, and the history is abrupt. CKD is disease defined as all the following except kidney damage for more than 3 months, kidney damage for less than 3 months, GFR less than 60, kidney size usually less than 8 centimeter. Answer will be
B.
B, right? Very good. So more than 3 months. It has to be more than 3 months. Very good. So I think all of you are very attentive in the class. I am very happy. So last question. All of the following condition causes palpable kidneys except if somebody has read the MacLeod, then they could have answered this. So that means if I touch your abdomen, if I palpate your abdomen by touching with my hand, I can feel the kidney. So what are the conditions where I don't get the kidneys? Number A, hydronephrosis. Number B, CKD or CGN. Number C, polycystic kidney disease. Number D, hypernephroma. Hypernephroma is a tumor, is a Wilms tumor. The other name is a Wilms tumor.
Sir, B.
Yes, it's a B, right? We have already discussed, because in chronic, it's a fibrosis. Your kidney has to be less unless there are some other conditions. So kidney size less than 8 centimeters. So it's B. Hydronephrosis means it's the dilatation of the kidneys. Polycystic kidney disease, of course, there are so many cysts, you can palpate the kidneys. Hypernephroma, there is a mass in the kidney. Surely you will palpate the kidneys. Okay, so one thing you don't palpate the kidneys is a CGN. Okay, very good, very good. So I think you are eligible to give final year exam also, I like this. Anyway, so I just put two questions. You don't have to answer all of this. I just want you to how the question of renal system will come. So you can see these are some few questions I have made. Maybe in ICM they will ask you what are the list some causes of hematuria. How will you investigate a patient present with hematuria? Then in your McLeod they have given you the causes of painless hematuria, painful hematuria. That also you can divide. You can divide in any other glomerular hematuria or non-glomerular hematuria. You write the tumors or maybe some stones, some glomerular nephritis. Is there some schistosomiasis, urethritis, UTI? You can just write. And tuberculosis, renal tuberculosis also can cause hematuria. So you can go through your McLeod. They were given you such a beautiful picture, which you'll never forget that I used to draw to remember my causes of hematuria. Painless and painful hematuria. Sometimes they came with the painless hematuria. Sometimes the patient comes with a painful hematuria. Usually, painful hematuria are due to the stones, right, or due to the infections. Painless hematuria are usually due to tuberculosis or some hypertension also can cause hematuria. They are painless hematuria. So you can divide and get better marks. How will you investigate? So you have to do some urine routine. You have to do sometimes it due to the bleeding disorders, whether then you have to do some whether the patient is suffering from post-ischemic glomerular nephritis, PSGN, then maybe you have to do some ASO titers, or maybe you have to do USC, maybe you have to do X-ray, CT scan to see the stones, right? So many things you can investigate. Number two, a 22-year female presented with a history of periorbital puffiness, passage of cola urine. On examination, her blood pressure was high and urinary analysis revealed 2 plus protein. So what are we dealing with? Nephrotic or nephritic?
Nephritic.
Very good. So nephritic syndrome, right? So there are so many causes of nephritic syndrome because we have discussed that nephrotic don't have blood in the urine, so there is no cola urine. Nephrotic usually don't have hypertension, and if it's nephrotic, then it is usually 4 plus protein. 4 plus protein is massive proteinuria. Okay? So they're asking you causes of nephritic syndrome that can be due to Staphylococcus, that can be due to some lupus autoimmune disease. There are so many causes of nephritis. Even bacterial endocarditis can cause nephritic syndrome. Enteric fever can cause nephritic syndrome after 2 weeks. After the first week, at the end of the first week or beginning of the second week. Even typhoid can cause nephritic syndrome. There are so many causes. Autoimmune causes are there. IgA nephropathy are there. So you can just write some possible causes at your level. I will investigate again urinary, kidney function test, USC. Like sometimes we do biopsy. Sometimes we send ANA, dsDNA to diagnose lupus, nephritis, systemic lupus erythematosus. Sometimes we send complement level also. So that depends upon you how much you want to write. And suddenly there is a complication nephrotic syndrome. So complication of nephrotic syndrome can be if you are losing so much of protein, there can be edema, there can be cellulitis because last time I showed you a picture, there's a blister formation. In nephrotic syndrome, if the skin are so much stretched, if the skin has so much of stretched, then the integrity of the skin is lost. The tight junction are lost. The desmosomes, they all are lost, and sometimes the bacteria from the skin can easily penetrate. So they are very highly susceptible for infections of nephrotic syndrome because of low protein, and you are losing not only the albumin and protein in the urine, you are losing immunoglobulins also because they are also protein. You are losing so many antithrombin 3. Have you heard antithrombin 3? I guess so. So antithrombin 3, yes. So right. So you become more hypercoagulable if they are endogenous anticoagulants, right? And so if you lose antithrombin 3, then you might have some hypercoagulability. So they are more prone to get thrombosis, spontaneous thrombosis, renal vein. They can have more of infections, delayed wound healing because of infection. There are so many other complication can be there. So you can just write 2-3 complication, and this is how the question will come in the short answer questions, or we get PBQ. This is not SAQ. This is PBQ, problem based learning, right? So they have given you problem, and you have to know what they are trying to ask, and then there are subsequent tail questions are there. Then you have to answer those. Okay, so I think that much is for my renal diseases. If you have any question, please ask me now. If you have any questions later on also, please you can send me in this chat room. I will definitely try to answer you. I think because of this corona, we could not see each other, but I hope I can deliver some of the kidney diseases. If you want any classes next time, you can always tell me, text me, or you can get my number and you can send message. Okay, you all stay safe, and we'll see you soon. Thank you.
Thank you, sir.
Thank you, sir.
Thank you.